Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Meet the Professor. Today we talk about the management of small cell lung cancer with Dr. Carl Gay from the MD Anderson Cancer Center in Houston. This is our second webinar. We did another one recently with Dr. Sands in this series. And as always, if you have any questions or cases you'd like to present, just type them into the chat room. We'll talk about as many of these as we have time. There's like a 1 minute, 10 item survey that we're sending out to you. If you could please take that before and after the meeting, it really helps us a lot to understand what your needs are. If you're into audio programs, we know a lot of people end up listening to these webinars in their car and while they're working out. Check out our Oncology Today podcast series, including a recent program on papers presented in lung cancer from the 2022 ASCO meeting with Dr. Sabari. Next week, we'll be doing another program in our ovarian cancer series with Dr. LaRue. And then we'll be continuing our HER2-positive breast cancer series with Dr. Lin from Dana-Farber. The next day, we'll be starting a new series on multiple myeloma with Dr. Loneal. And then on Saturday, October 22nd, is another one of our all-day spectaculars. We have 15 investigators. We'll be down in Orlando with the Florida Cancer Specialists. We'll be covering 20 tumor types, the latest papers, and what they mean in terms of clinical practice. So check that out. Find a comfortable spot that Saturday. If you're not in Orlando, you can check it out online. But today we're here to talk about small cell cancer. And as always, we have a bunch of cases from general medical oncologists and community-based practice that we'll be presenting here today to Dr. Gay. I'm going to start out, actually, in a minute, we're going to start with a couple of papers that Dr. Gay did. But Carl, last night in our webinar, there was a doc who said, hey, can I submit some cases for tomorrow night? And I said, sure, in the chat room. So here they are. This is Dr. Abdul Hanan from Grand Forks, North Dakota. Thanks so much, Dr. Hanan. Hopefully we can help you out a little bit. Amazingly, Carl, he has 2 cases of patients with small cell that are non-pulmonary. So we're going to ask you to provide feedback on that. But just first, I'm just kind of curious. We were chatting a little bit about this, why you ended up getting into small cell. You know, I hear all these cases from docs in practice. It's so frustrating to see, patients responding to chemo and then, going downhill. How did you end up getting interested in this?
Yeah, I mean, I think you can view the natural history of small cell lung cancer as either a source of frustration or a source of opportunity, right? And I think that any disease that has the ability to respond to that degree to even conventional cytotoxics feels like there's a path forward there to enhance that response, right? It's not a disease that responds to nothing. It's not a disease that's static. And so I really felt like there was an opportunity to consolidate the disease and really transform the outcomes for small cell patients. And then the lack of personalization of therapy there, again, it felt like we were lagging behind non-small cell lung cancer, and there was a need to kind of focus greater interest on it in that regard.
Seems like every part of oncology is exploding nowadays, maybe with the exception of pancreatic cancer, but it seems like every corner there's so much going on. HCC, hepatobiliary disease. But anyhow, let's get back to these 2 cases. Dr. Hanan, see if we can help them out a little bit. Young patients, 39-year-old woman, the smoking history, has rectal bleeding, has a presacral mass there. And the biopsy looks like it's small cell cancer. How would you treat the patient? Would you opt for PCI? Any thoughts about this case?
Yeah, I mean, I think it's sufficient to say that extrapulmonary small cell remains kind of a black box in terms of in terms of standard of care, and for the most part is extrapolated from small cell lung cancer with occasional sort of peppering of that particular primary site's standard of care. In a case like this, it sounds like this patient may have localized disease. And so I think opting for some definitive treatment, without further description, I don't know whether it's surgically resectable, but I do think if it appears to be a very localized lesion, then either surgery or perhaps chemoradiation would be appropriate. It sounds like they are planning to do something definitive, given the question about prophylactic cranial irradiation. Most of the admittedly small retrospective studies have shown that brain metastases are significantly less common in extrapulmonary small cell than in small cell of the lung. They're not unheard of, but but infrequent enough that probably prophylactic cranial radiation would not be considered a standard approach here, even in somebody at this age. So it's hard to rule definitively on PCI, but I would generally rule against it in patients with extrapulmonary disease.
So actually, Dr. Hanan's in the chat room. He says they use cis, etoposide, and radiation therapy. So I guess kind of like limited stage small cell, basically. And we'll get into that.
I think I would have approached it exactly that same way.
So, yeah, one of the reactions we get from docs in practice is, they feel confused sometimes, and they feel good when they see that other people maybe are having a hard time figuring out what to do because there's no data. And here's another situation that Dr. Hanan has, 81-year-old woman, right-sided colon mass, small cell cancer, looks like it was removed. 2 of 28 lymph nodes are positive. And the question is further management. He says the patient's 81, not eligible for CIs. Again, question mark PCI, and quote, she cannot get XRT to the abdomen. So what would you think about it? It sounds like a colon small cell.
Yeah, and maybe a mixed adeno and small cell. One additional thing I might advocate for in this case that may seem a little bit unusual for small cell practice is to get molecular profiling here, because occasionally these can be BRAF mutated. And it seems to be sort of a predilection for transformation in the BRAF V600E population. So that may open up a treatment avenue. Again, this is coming from somebody that doesn't routinely treat colorectal cancer. But, for a patient like this where you had a surgery that sort of incidentally found small cell, but now appears to have had definitive treatment for that, I would advocate for some form of adjuvant therapy. In a case where cis is not, a patient's not cis eligible, carbo is a reasonable substitute, and I probably would approach it with a carbo-etoposide combination.
So, any thoughts about this SWOG study that's actually looking at extrapulmonary small cell? But this, I guess, is metastatic disease, and neither of these patients have Mets. But any thoughts about this trial? I'm amazed. You try to get 189 people. That sounds challenging.
It's going to be a challenging trial to enroll because of the rarity of this disease. But I think it's a really critical question. We, as I mentioned before, we extrapolate from small cell lung cancer here. And so many folks are already using a chemoimmunotherapy combination and appealing to insurers for that. But we don't know if these are more or less sensitive to anti-PD-L1 than small cell that arises from the lung. And so I think it's an important study to do if it turns out to be practical to actually enroll it.
And also to our audience, if you have a patient with metastatic disease, maybe try to get them in this study and help us figure out how to treat these patients. All right, well, before we get into some of the cases we have prepared, I want to ask you about a couple papers. And this first one I put in here really because I have no idea about this field at all, but it looked really interesting. A lot of great graphics in the field. So without challenging my translational knowledge too much, can you give me kind of a broad overview of what this is all about? It seems really interesting.
Yeah, but in this, we were sort of reviewing what was known and then combining that with a little bit of our own internal lab-based data on how the metabolome influences both small cell and non-small cells' interaction with its microenvironment. And I think small cell is where our research focus is. One of the things about small cell is it's a very greedy tumor when it comes to energy, and so the level of glycolysis in small cell sort of outpaces the body's ability to do anything with the products of glycolysis, or outpaces the cancer cell's ability to do it, I should say. And so you end up with these high levels of lactate. This Warburg effect is well characterized in cancer, but it seems to be really at an extreme in small cell, and may, at least in part, explain the immune desert phenotype that we see in small cell lung cancer, because that low pH creates a really inhospitable environment for T cells. And any folks that know anything about small cell histology will know that you're almost never T cells, despite the high TMB and all the things that you might think make these tumors really immunogenic. They don't seem to be. And so there's something that's preventing the T cells from infiltrating. And we propose that it's at least in part the metabolomics of the cancer cell itself.
Interesting. Any specific therapeutic options that may be tied into this kind of strategy?
The things that are already in under investigation, like metformin, that are meant to influence the cellular metabolism, I think are probably not going to make a dramatic change here. There are a number of very preclinical, like not yet first in human compounds that may block the secretion of lactate or may block glutamine uptake, which is a really important resource for energy of small cell and other tumors. And so, I would say things that aren't quite ready for prime time, but certainly an approach that's worth pursuing for the future.
So here's another set of work that's kind of translational that I found that you've been involved with. Very interesting. I know I've talked to your colleague John Haymock about his view or his work on subsets of non-small cell. This seems similar in terms of small cell. Kind of what's behind this idea, and what do we know about these subgroups?
Yeah. So basically, our approach here was that. That although small cell seems to be genomically homogeneous, there's essentially a 100% loss of P53 and RB1. And so it's not like non-small cell where you have these various driver oncogenes, right? You lose tumor suppressors in small cell. And those things don't reveal a lot of heterogeneity about the disease and also don't offer therapeutic targets. But what we had observed is that transcriptionally, there was a great deal of heterogeneity in small cell tumors. And we wondered whether or not that transcriptional heterogeneity followed kind of a predictable pattern, and whether or not that influenced outcomes both with standard of care therapies and with some experimental therapies. And what we found was that you could routinely, as illustrated here on the left, you could routinely classify small cell lung cancer transcriptome as one of 4 subtypes. 3 of those are based around the differential expression of 3 transcription factors: ASCL1, NeuroD1, and PAL2F3. And then we identified a subtype that was not previously appreciated. We called the inflamed subtype because sort of is the exception that proves the rule that I mentioned earlier, that small cell lung cancer is an immune desert. So this rare subset, maybe 15 to 20% of small cell lung cancer, is not. It has high T cell infiltration, high immune checkpoint expression. And based on that, we predicted that those may be the tumors that are getting benefit from immunotherapy, because clearly the benefits of immunotherapy are modest in an all-comers unselected population. But that's all we have. We don't have biomarkers. And indeed, that's exactly what we found. We found in the Empower 133 data that if we classified these tumors into subtypes, those inflamed tumors experienced a near doubling of their survival, whereas the more common uninflamed small cell lung cancer subtypes experience very little benefit at all. Certainly no sign of detriment, but clearly a lot of the work in kind of pulling up the Kaplan-Meier curve is hoisted on the shoulders of these rare inflamed tumors here. So it makes us think that A, you could select patients that are going to get the best benefit from this, and B, we need to be focusing on ways to better inflame these other subtypes that are not really experiencing interaction from the immune system.
So are these subtypes going to be incorporated into ongoing clinical trial design?
Yeah, so they absolutely are. And so we've worked out, at least preliminarily, CLIA assays to assign tumors into the correct subtype, using immunohistochemistry. I think there may be more sophisticated ways to do that in the future using both tissue and blood-based biomarkers. DNA methylomics, in particular, have shown a lot of promise for this. And so I think certainly within the year, we expect to have the first trials that are assigning patients to therapy based on their transcriptional subtype.
So we got a great case in the chat room. Tell me what you think about this from Julia. Esophageal small cell with METs, status post carbo-etoposide atezo for 2 years, progressed to the adrenal and gets topotecan for 20 cycles. What's next? She asks.
Goodness, yeah. I mean, that's a really exceptional responder to the therapies that they've had. And so I wonder if that patient, if they were on carbo-etoposide atezo for 2 years, my guess is that there was a long platinum-free interval in there. If most of those 2 years were spent on atezolizumab maintenance. So one option, although it's not a particularly sexy option, I suppose, is retreatment with platinum, often combined with perhaps a different partner like irinotecan. But there's a lot of the data suggests that in small cell of the lung anyway, retreatment with platinum in patients that have a long platinum-free interval is probably better than anything else out there. There's not data for lurbinectedin in extrapulmonary small cell, but I don't think it would hurt to consider it. There's no reason to think mechanistically it would not work there as well as it works in small cell lung. There's also better data for ipi-nivo in combination, and it's actually in the ipilimumab and nivolumab in the NCCN guidelines for these tumors. This patient obviously has had PD-L1 in the past, but we know that sometimes the combination is able to generate a response even in patients that are PD or PD-L1 refractory.
So before we get into the cases, you mentioned PD-1. Can you comment on what you see in patients with small cell in terms of PD-1 levels?
Yeah, so if you're talking about tumor expression of PD-L1, the levels are extremely low. So the average small cell lung cancer tumor for sure is negative. Sometimes you will see some weak PD-L1 expression if you use the combined proportion score and you incorporate the tumor microenvironment. But for the most part, these are tumors that are negative for immune checkpoints.
And so I guess is there enough positives that you can say there's a correlation or predictive benefit, or we don't know at this point?
We did find in the inflamed subtype that we identified that PD-L1 is higher in that subtype, along with most of the other immune checkpoints. And so it's possible that if you had PD-L1 expression combined with other biomarkers, perhaps you may be able to capture some of these patients that are apt. But I think it'd be so difficult to enroll a trial that required PD-L1 expression, especially robust PD-L1 expression, beyond maybe 1% or something. I think it would be very challenging to validate.
So one more question from the chat room is from Dr. Hanan again, asking about these extrapulmonary. Is it possible there is a primary, you just can't see it? It's like an occult primary.
I think we certainly see patients like that, in our clinic where we think, especially if it's a patient that demographically fits small cell of the lung, a heavy smoker, an older patient, where we see a primary site somewhere that doesn't really add up. We often wonder whether there's an occult primary. I think that's part of the reason why all of these patients, no matter how early stage you think you've caught them and resected their tumor, why they need systemic therapy to eliminate any occult disease as well.
I was bragging about our chat room in a webinar last night because we get such great comments and questions. And here we may have to do another hour with you on the cases we prepared. But I got to ask you about this case from Jeffrey, 30-year-old with germline BRCA2, diagnosed with stage 4 liver mets, small cell cancer of the tail of the pancreas, treated with carbo-VP16 atezo, followed by atezo olaparib maintenance. Kind of shades of breast cancer, triple negative disease, and then progressed after 5 months of maintenance. So any advice, but also I'm curious about the case in general up to now, and then what's next?
Yeah, I mean, this person already, I think, stole my brightest idea, which was to try to get this patient onto a PARP inhibitor trial or try to appeal to the insurance to get it approved. You wonder if this maybe started out as a conventional pancreatic adeno and then transformed or something, given the BRCA background. BRCA alterations are not unheard of, but are pretty rare in small cell tumors of any variety. I would keep hammering away at the DNA damage repair pathways. For small cell of the lung, there's promising data with combining PARP inhibitors and temozolomide to the point where I've seen that successfully delivered off label. And so I think that's something that could be considered there. But this seems like a patient that would really potentially benefit from being seen at a cancer center that had an early phase clinical trial group that was sort of offering tumor agnostic trials targeting PARP and ATR and other things of that variety in kind of a primary site agnostic way. I mean, we certainly have trials like that here where if you're BRCA mutant, they don't care what your primary is. They're just going to hit you with DNA damage, and so it feels like that's a patient that might be able to gain from something of an approach like that.
All right, let's get into our cases. We're going to start out with a couple of cases that bring up some basic but really important questions. This is a patient, 60-year-old woman, a patient of Dr. Kumar, who starts out with extensive stage disease, but has a met in a node in the adrenal, and then a little residual, which goes away with the treatment, but has some residual disease in the lung after treatment. Here's Dr. Kumar.
This is a 60-year-old white female, left upper lobe mass, 3 into 2.5 centimeter. Biopsy showed small cell carcinoma. PET scan showed mediastinal node and a splenic hilar lymph node, which was positive. She was started on carboplatin, etoposide, and atezolizumab. She achieved good partial remission, 4 cycles. The splenic lymph node, everything disappeared except for small residual mass in the lung. At this point, question to the expert would be, can we consider radiation therapy to the splenic hilar lymph node and radiation to her lung and mediastinal node because she's relatively young? Or one should just say she's stage 4 and wait and watch for recurrence?
So relatively long, limited METs. What do you think about the idea of sort of a consolidation for these two areas?
So I'm a believer in consolidative thoracic radiation anyway for patients that achieve a good partial response with residual thoracic disease. I know that that data predates the use of atezolizumab, and there's an NRG-LU007 study that's going on right now that's trying to answer that question whether consolidative thoracic radiation still makes sense in the immunotherapy era, and they are allowing consolidation of extrapulmonary sites of disease. So I think if that splenic node has completely disappeared, I'm not sure I would champion going after that with radiation. But if there's still a target there, I think it is reasonable to give kind of an almost oligometastatic local consolidation approach to a young patient that has because you're going to run out of options for small cell patients, right? And so you want to be as aggressive up front in consolidating this response as you can, is my approach.
So Param in the chat room wants to know, when consolidating with RT, would you hold the atezo?
I have generally just continued the atezo and asked, just to make myself feel a little bit better, asked my radiation colleagues to just time their consolidative therapy between 2 cycles of atezo, right? You have a 3 or 4 week interval depending on which atezo paradigm you're following. And that's usually long enough to get in 10 days of radiation. It makes me feel better because there's not explicitly safety data for using it in this regard, but in other tumor types, we've used them together without any apparent increased risk for pneumonitis.
So back to Hanan, Dr. Hanan in the chat room asks, this is interesting, we were talking about extrapulmonary. What's the smoking status of people with extrapulmonary? And also, you were telling me before we started about non-smokers with small cell in Asia and the Asian trials. So 2 issues about smoking.
Yeah, smoking status is a really interesting feature or demographic feature that we'll hear more about in the near future. You know, the association of smoking with small cell lung cancer had always been, 95+% of these patients were heavy smokers. And for various reasons, I think that's becoming less true. I think some of it is just appreciation for these patients. Some of it is transformation in driver mutant populations. So, for example, EGFR mutant patients that transform either de novo or after pressure from osimertinib. So there is an increasing number of these patients, no matter who you ask. Extrapulmonary, from an extrapulmonary standpoint, it really varies. So I think there are certain extrapulmonary sites, take cervical, for example, where smoking seems to be almost immaterial to whether these patients develop small cell. Whereas in some other extrapulmonary sites, I think if smoking is generally associated with an increased risk for any primary disease from that site, there does seem to be a little bit of a skew toward enhancing the risk for small cell lung cancer, although certainly nowhere else is it as clear cut as in small cell of the lung.
What about Asian patients?
Yeah,
you were saying they're more
that's something that we just don't understand, and I'm dying to have an answer to this. So we've put together a cohort here at our institution of patients that have low or never smoking histories with small cell lung cancer to explore the genomics of this. And I would love to see similar data come from East Asian and South Asian cohorts, because I do wonder if some of these are transformations de novo, because they obviously there's a higher rate of things like EGFR mutations in that population. But then you also wonder if there's something either inherent in the genetics or inherent in the environment that might be putting them at risk for something that's classically been associated with smoking. So it's a question I wish I had the answer to. I think it's going to be a fascinating case study to come.
Interesting. Okay, let's go to another case. This is from Dr. Morgenstein. This is one of the most common questions I get from oncologists, which is, limited stage disease does not necessarily have the greatest prognosis. And People want to know about using IOs. So here's the case from Dr. Morgenstein.
71-year-old female, very heavy smoker. She was on a lung cancer screening protocol and was found to have a very small lung nodule and lymphadenopathy and discovered to have small cell lung cancer. Her staging was negative. She received chemotherapy with XRT. She had a CR and was monitored very, very carefully. Unfortunately, 6 months later, she developed widespread metastatic disease. We tried to give her carboplatin, VP16, as well as atezolizumab. She tolerated therapy well, but progressed quite rapidly. So my question is IO now the standard of care in conjunction with chemotherapy? Are there any patients who we wouldn't use this in? And should IOs be continued after progression? It's truly unfortunate because we saw this patient right before we opened a clinical trial looking at IO therapy with or without chemo radiation. But off trial, would anybody use either concurrent chemo IO with radiation or adjuvant off study, considering that these patients have substantially high risks of recurrence?
Yeah, I think that the trials that he brings up there are hopefully going to answer this question for us soon. And so I'm not aware, certainly in the United States, of anybody that is aggressive enough to try to incorporate immunotherapy into the standard of care for a limited stage patient. Although I think all of us want to try that, right? So there's a recently completed NRG study that will read out hopefully in the near future that's approaching this precise question. And so it does feel like a missed opportunity because these patients have a complete response that you're not giving them something in the consolidative setting. And so I think there's an increasing appreciation in trial design for small cell patients, both in the limited and the extensive stage setting, that we need to be more aggressive in the maintenance phase, right? That the classic approach of just kind of resting on the laurels of a really great PET scan after four cycles of therapy and saying, well, I know this is going to come back, but there's nothing I can do about it. It's just not good enough for these patients. But how we personalize those maintenance therapies and the degree to which patients can tolerate intensification in the maintenance setting after something like chemoradiation, I think remains an open question. So I hope that immunotherapy does prove to benefit these patients in the limited stage setting, but I think like the extensive stage setting, it will probably be a narrow benefit restricted to a subset of patients. And so there's likely to be a lot of work to do in this setting.
So we had that patient with BRCA, and we brought up the issue of PARP, and there, ovarian cancer, you see that with the PARP maintenance after chemo. So that, I guess that's one example.
And there's a trial that's doing exactly that for limited stage disease that's open and enrolling right now. It's offering immunotherapy with or without PARP inhibitors for in the maintenance setting. And then there's another trial in the extensive stage setting that's doing exactly that based on Schleffin-11 status. And so you're right on the money with the thought of trying PARP in the maintenance phase.
Well, yeah, but I was talking about ovarian cancer, PARP and small cell?
For sure. So while they don't have the same, BRCA, rates that we see in other tumors, they are sensitive to DNA damaging agents, in part because of the universal loss of P53 and RB1, which leaves them susceptible to further derangement and DNA damage repair. And so they're heavily dependent on PARP. And so they small cell tumors express very, very high levels of PARP. PARP monotherapy has not proven to be all that promising in small cell, but in combination with temozolomide, we've seen response rates approaching 40%. And I think there's a lot of data also suggesting that there may be a synergy with PARP inhibition and immunotherapy in helping to inflame the tumor microenvironment.
Hassan in the chat room wants to know whether you're a proponent of BID radiotherapy in limited stage small cell.
But I think it depends on the facility. We have the capacity to do that for all of our small cell patients. And anecdotally, I find that patients tolerate the radiation better if they're just done with it sooner, right? I mean, they finish with radiation a little over 3 weeks instead of spreading it out over 7 weeks that way. And then they can just get on with the healing from radiation. The thought was always that it would be more toxic, but the data has not really borne that out. The toxicities, esophagitis, pneumonitis were relatively similar. And so I do favor BID where it's available. But for example, in our community hospitals where I trained as a fellow, we didn't have that capacity. And, I think it's not doing a major disservice to the patients to do once daily radiation.
So I want to ask you about a couple more papers that you did. We don't think too much about surgery in small cell. Of course, this case we just heard, that's what happened. The patient didn't know that it had a small cell and was found at surgery. This is a series looking at patients who've had surgery, predictors of survival. Any comment about this scenario and how you manage it, and also what you do about adjuvant therapy? Do you use the non-small cell guideline or just give everybody adjuvant therapy?
That's great questions. And so I'll say my answer also applies to patients that may end up getting SBRT for a very early stage small cell lesion, which we see from time to time. And so sometimes these are incidentally surgically resected because it's a small nodule that it's just as easy to resect as it is to biopsy, and we find out later that it's small cell. In a patient that has a T1 or T2 tumor without nodal involvement, I think it's very reasonable to consider surgery or to consider SBRT. And for all of those patients, unless there's a clear-cut contraindication the patient refuses, I advocate for adjuvant therapy. And so even for very early stage. So I do not apply the sort of 4 centimeter high-risk feature cutoffs that we use in non-small cell lung cancer. I give it to even very early stage patients. And there's data suggesting there's an overall survival benefit to using that approach.
Another wild case from the chat room. Hassan has a 58-year-old patient presented with a 3 centimeter lung mass, bilateral adrenal mets, 10 centimeters, and then gets carboetopicide, excellent response, topotecan later, Taxol later, consolidation. Basically, he's been in complete response now from chemo, it sounds like, for 15 years. Why is this patient different? Why is this different than other patients with small cell?
Yeah, I have a patient or two like this in my clinic panel, and I know of a few others at our institution that have these sort of 10-year histories of complete responses to relatively pedestrian therapies. I think generally these are probably patients that have some sort of DNA damage alteration that makes them ultra sensitive to chemotherapy, or they may be patients that fall into this inflamed subtype, because we have a little suspicion that those are patients that even without immunotherapy may be able to provoke an anti-tumor immune response. With even just when you experience cytotoxics, and so there's something provoked the immune system here in order to protect this patient from a relapse for all this time, right? It can't just be cytotoxics alone.
I guess you don't see Pol E in small cell, right?
Very, very occasionally. Yeah, I mean less than 1%, certainly.
So what about Dr. Morgenstein's question about who do you not give an IO to? So, in general, when we talk about IOs, prior autoimmune, transplants, et cetera, et cetera. But I'm curious, what about paraneoplastic syndromes? How do you approach that? Do you just go ahead and treat everybody?
Yeah, so I think it's important to distinguish endocrine and paraneoplastic syndromes from the more sort of neural paraneoplastic syndromes that are autoantibody mediated. So endocrine paraneoplastic syndromes, I certainly don't have any qualms. Those tumors or those paraneoplastic syndromes generally get better with cytoreduction. In patients that have, while they're rare, that have the, autoantibody Lambert-Eaton and stiff person syndrome, things like this, I would have some hesitation at offering immunotherapy. And part of that is just because the benefit of immunotherapy is relatively modest in small cell lung cancer. And so the risk-benefit calculus, I think, is a bit different there than in tumor types melanoma or cutaneous squame. Some of these tumors that have these really dramatic responses to immunotherapy, maybe you sort of cross your fingers and close your eyes and try it. But, in an all-comers population, offering 2 months of overall survival benefit for something that could threaten a patient's life, some of these paraneoplastic syndromes can be very serious. I would have some hesitation, although I think with careful counseling, and I think it's not unreasonable, but I would have some reservations there.
So we've seen some updates of these first-line trials. We put them in the slide deck if people want to read about it. It's always been interesting to me that pembrolizumab, which had a very similar approach, didn't reach statistical significance. We just saw this update here. It still looks like it doesn't reach statistical. Kind of reminds me of the locally advanced durvalumab situation where durvalumab is positive, pembro is negative. Usually people say, oh, well, bad luck, that people believe that it's not an inherent difference between these agents. Why was pembro negative and the other two positive, for example?
Yeah, I tend to ascribe to that, not particularly intellectual hypothesis as well, that it's just sort of bad luck, that the benefit, there's roughly the same benefit that's there, right? Kind of a 1 to 2 month benefit. And I think it's just partly lucky statistical design and probably lucky enrollment. I think the benefit is modest across the board for PD-1 and PD-L1s. We're lucky to have the two that we have. I think they make nice things to build upon, but I don't think it speaks to an inherent resistance to Pembro or Nivo, for example, in this setting.
So here's the update of the Empower study. You can check it out. The one thing that I thought was interesting, we were talking about PD-1, and it looks like PD-1 was not particularly predictive of benefit. And I guess we were talking about that before.
Yeah, I think that, there's really not been any conclusive evidence that PD-L1 expression or tumor mutational burden, certainly not in a prospective way, are able to predict benefit. So we're stuck given the one-size-fits-all approach when it comes to immunotherapy, which is really unsatisfying.
And here's the update to the durvalumab, the Caspian study. But here also you see the, I guess maybe we need to put it in there, there it is. Yeah, Durva-Tremi data. Doesn't look like that much better. And kind of in general, that strategy doesn't seem to be that effective. Any thoughts?
I agree with you. And this was pretty disappointing because in the relapse setting, the combination of ipilimumab and nivolumab seemed to offer more benefit than nivolumab alone. So I think the thought was, well, if these patients can tolerate combination immunotherapy in combination with chemo, which is a big if, right, that there will be some enhancement of the response there. I think the enthusiasm on that has really cooled now in the extensive stage setting. And so it may be about patient selection. If you're able to identify these inflamed patients, maybe they would get more benefit out of combination immunotherapy than they would single agent immunotherapies. But I think in an all-comers population, it's probably not going to be a major path forward.
So last night we did the program on head and neck cancer. We were talking about that with nasopharyngeal cancer. There are 3 checkpoint inhibitors that have positive phase 3 trials that come from Asia, but none with Pembro, Nivo, or anything out of the United States. We see a lot of trials coming from Asia that we try to understand. Here's another PD-1 inhibitor. Well, actually, this is PD-1, so I guess this is the first time PD-1 was actually looked at. But again, it looks like what we've been seeing pretty much mirrors the same numbers. And then this other agent, I'm not even going to try to pronounce it, but again, kind of a Me Too, anastrozole, letrozole thing to me. Any comments about these drugs that come from China?
I think that there's certain subsets of lung cancers in general, including small cell lung cancer, seem to be more common in East Asian populations. So I think it's important to consider these data. I think there's a benefit to enrolling patients in East Asia because of the frequency that they see some things like this, EGFR, et cetera, there. But I think we also have to be careful about applying them to other populations. And it's not a commentary on the trial itself. It's just that I had mentioned to you offline, for example, that the trial with the trial with the anti-PD-1 from China had a really high rate of never smokers or very light smokers who had developed small cell lung cancer. And that's not something we really see as much in the United States. So we don't know how to extrapolate from that, right? Are those patients are doing better in general from immunotherapy? Are they doing worse? And so I think we have to. Again, just exercise caution when applying that to our standard of care practice here.
All right, let's get back to some cases from practice. This is a patient of Dr. Miller, 66-year-old man with extensive stage disease, gets carboetopicide atezo, but then has disease progression and also now has CNS mets. And actually, he ended up getting lurbinectinib alternating with radiation therapy, but as you'll hear, he also had an interesting NGS assay. Here's Dr. Miller.
So here's images when we first got his initial CT scans. So not surprising that the top image here is the CT scan was without contrast. His initial scan, he had extensive hilar and mediastinal involvement. I think this is really why he was suffering so many side effects. And this is actually a scan only after his first 2 cycles of therapy with substantial improvement there, had resolution of that right-sided diffusion and significant reduction in the mediastinal mass. And that was, again, only after 2 cycles. Here, unfortunately, is showing where he had a very good response. He had a best partial response where he started. That was on the right side, so 2 months earlier, was a CT abdomen and pelvis. And while that large liver mass had shrunk quite substantially on the left side is when he had progression. And this was after just about 2 months of immunotherapy. I'm curious to hear for our small cell lung cancer population, do we routinely send for molecular panels? For him, I think it was a good idea. He did have an FGFR1 gain, and this actually did have a phase 1 clinical trial that was an option for him. My biggest problem that I've had is how do we deal with this patient population when they have a refractory platinum disease? Lurbinectedin's our only real option, but they're also having progression in the CNS, and that's a really tough one. What would be the role of something like trilaciclib in these patients who frequently are dealing with neutropenia since they've been on multiple lines of chemotherapy?
So a bunch of things to comment on in the case. Any thoughts?
Yeah, several good questions in there. And so I'll try to pick them off one at a time here, but redirect me if I miss anything. And so the question about whether or not we send molecular profiling in small cell lung cancer, I guess is yes, when we can successfully justify it. And so we'll occasionally, for example, get a liquid biopsy on a patient that we can see has metastatic cancer, lung cancer, without having a diagnosis yet, right? And so sometimes these patients turn out to be small cell, and we'll have the luxury of molecular profiling. You know, there are not common targetable alterations in small cell lung cancer, and so it's hard to justify it in general. It's very useful from a translational and a preclinical perspective, but I'm not sure, you know, when you're dealing with insurance companies that we can routinely do this testing. Hopefully in the near future, we can get towards a more personalized approach. But, you know, I as much as I advocate for it as somebody that thinks more information is power, you know, I think we have to be mindful of, you know, the patients potentially suffering the economic consequences of ordering a test that's not standard of care, and it can be expensive. That said, they did find a targetable alteration here, and I think anything that opens up clinical trial avenues for small cell lung cancer patients is obviously a good thing, because in the particularly in the platinum refractory setting, right, there's a patient that had a very short platinum-free interval. And the question was, you know, lurbinectedin versus anything else in this population. You know, lurbinectedin, like most things in small cell, showed a better response rate in patients that had a longer platinum-free interval. The response rate wasn't 0 for platinum refractory patients, but it was lower. And so these are patients, I mean, all of my small cell patients, I try to look for clinical trials, right? But I think these are patients in particular that I try to get somewhere where there's a clinical trial option for them. And so, you know, while I think lurbinectedin would still be considered the standard of care here, topotecan, I suppose, I think you have to have very modest expectations for the benefit that you're likely to gain. And so it'd be nice to try something different. We just don't have, you know, all that we have are cytotoxics in the relapse setting that you can routinely get insurance to cover.
He was bringing up the issue to me of CNS activity of treatments for small cell upfront treatment, but also second and third line, such as lurbinectin. He had concerns about whether lurbinectin would even get into the CNS, and he was kind of alternating stereotactic spot welding, so to speak. Are there times where you have a patient with brain mets and small cell where you just give systemic therapy? And for example, in the first line situation, if the CNS mets are asymptomatic and maybe small and without edema?
Yeah, that's a great secondary point from the case. And so in the frontline setting for patients that have asymptomatic brain mets, I will routinely treat with systemic therapy alone and often achieve a significant response in the CNS. And so clearly we're getting some CNS penetration from our standard platinum etoposide combos. It's not clear that immunotherapy adds any benefit to that. You know, beyond the frontline setting, in these patients that are less perhaps chemosensitive, you do start to worry about your ability not only to penetrate the brain, but actually get response from the disease that's there in the brain. Anecdotally, lurbinectedin does seem to, you know, people have described cases to me where they saw responses in patients that had brain mets. It's a reason that I do employ temozolomide as an off-label but NCCN recommended therapy for patients, because that's a drug that gets very good blood-brain barrier penetration. The response rate in the CNS as a single agent is actually higher than the response rate elsewhere for small cell lung cancer patients. And so in patients where we've exhausted radiation options, but they have progressive disease in the brain, that's, you know, in a patient that's still well enough to continue therapy and wants to continue, temozolomide, I think, is a good option there to ensure that you're giving them some chance at responding in the CNS.
So Param in the chat room wants to know how to figure out whether a patient is, quote, inflamed or not with small cell. This subtype thing that you're working on, is that going to become a commercially available assay that you can actually order?
So I mean, certainly we've developed it partly with that in mind. I think the first step will be prospective enrollment on clinical trials. And I think the interest in developing it as a commercial assay will depend on its success in predicting something. We've now seen retrospective data from both Empower 133 and Caspian that validates the inflamed subgroup. And so certainly there's nothing left to prove in the retrospective setting. As for exactly how we're going to identify these patients, I think IHC is going to capture a lot of them, but I do think that we're going to need a more sophisticated assay, and probably an assay with a lower dependency on tumor, because we often don't have a lot of archival specimens in small cell patients. They're often diagnosed just on fine needle aspirations. And so there's often not a lot to perform any additional IHC. And I've learned that the hard way from running trials that require archival specimens. And so we're working also on blood-based assays, because small cell lung cancer patients have an enormous burden of circulating tumor cells and circulating tumor DNA. And that's there for the picking, right? That you can get easily in clinic with a minimally invasive procedure. And so no way to know whether a tumor is inflamed yet in a practical sense, but hopefully within the next couple of years that will change.
So Dr. Miller was also asking about trilaciclib. What are your thoughts about that? It seems like, that it might be a consideration, particularly in terms of quality of life. We have some slides on that. I don't think we're going to get to it. But what's your take on this agent? Are you using it?
Yeah, so I think at the institutional level, we've only recently started to use it here. I think that, my initial response to it was, well, it wasn't compared to our conventional growth factors, which many of us commonly use for small cell anyway. But I think that the data on treatment delays that can be prevented with trilaciclib, certainly with our conventional growth factors, we're protecting the myeloid lineage, but not doing a lot about hemoglobin and platelets, whereas trilaciclib seems to protect all three. And so I do think that there's a role for it. Whether, I think he had mentioned it in the context of lurbinectedin. I know those studies are underway to see if it can be sort of safely deployed there. Whether or not it doesn't seem to have an overall survival or progression-free survival benefit necessarily, but the studies were not necessarily designed with these things in mind. And so I think it's reasonable to keep an open mind about whether or not protecting patients from the toxicities, which are, marked from small cell lung cancer therapy, could be its own weapon in your arsenal, so to speak.
So let's continue on with relapse disease. And one of the most common questions I hear from oncologists is the use of lurbinectedin. And this is a 62-year-old man who actually had dose reduction I want to ask you about. Here's the case from Dr. Gossain.
While he was on maintenance, he recurred in 4 months' time. He was initiated on lurbinectedin at 3.2 milligram per meter square, and he had increased fatigue and neuropathy while on it. With dose reduction to 2.5 milligram per meter square, he did well and responded for a total of 1 year time until recently, where he progressed and presented to the emergency department with SVC occlusion and extensive lymphadenopathy. At this point in time, he is being evaluated by radiation for palliative radiation therapy. The questions for the panel I have are, what are the typical side effects faculty has seen with the lurbinectedin, and did the dose reduction in a setting like this helped in better tolerability? Would you still consider nivo-ipi combination at all, or rather rely on docetaxel or topotecan as a third-line therapy? How does faculty sequence as lurbinectedin? Are they utilizing before or after initiating chemotherapy like docetaxel or topotecan? Though the indication is only for small cell lung cancer, I have a kidney patient who is small cell. Any thoughts of using lurbinectedin in that particular setting?
Another case with several good questions. So again, redirect me if I miss any of them. So the question about lurbinectedin sequence and dose reduction. So I think the general approach that I use in my practice, and that I see a lot of my colleagues using, is to deploy lurbinectedin commonly in the second line before we start using off-label single agent therapies like taxanes, or even topotecan or irinotecan. But I don't think that's set in stone. The typical side effects that I see with lurbinectedin include nausea, fatigue, and cytopenias. And the cytopenias are not, can be dose limiting in some cases. He mentioned in this patient neuropathy, which is not something that I've witnessed myself with lurbinectedin, but I have heard others describe. And so I routinely utilize this dose reduction from 3.2 to 2.5 milligram per meter squared, and I've seen patients continue to benefit on that. And frankly, I think to get, this is a patient that stayed on it for a year. I think it would be hard to keep the average small cell lung cancer patient on something like full dose lurbinectedin for a year's time. And so if you really want it to be a maintenance drug, which is what you hope to see in this setting, I think you do have to consider dose reductions rather than discontinuations of the drug. I think he also asked about using it on an extrapulmonary small cell. And I know that that's something that is of interest in the development of lurbinectedin, but obviously there's no clear-cut answer there. But I don't see any harm in trying, if I'm being honest, because these patients, the extrapulmonary small cells, often have even fewer standard of care options than small cell of the lung. It's depressing to turn to the NCCN guidelines and just sort of see refer to this as the direction, right? That's not very inspiring. And then the last thing he had asked about that I recall is whether or not the Nivo-Ipi combination in the relapse setting is still being utilized. And we did keep it on our formulary here, and I still think, the response rates were not insignificant, relative to other sort of dismal response rates that we see in the relapse setting with small cell. I think it's very case by case whether or not an insurer will consider the previous phase 2 data that has now been removed from the NCCN guidelines as a recommendation in patients because of the approval in the earlier setting for PD-L1. And so we've had less and less success in getting that. But I think if you're out of options or out of dealing with a patient that you don't think will tolerate cytotoxic therapy, I think it's reasonable to attempt.
So flipping back to some papers, I was curious about this SLFN, or SLFN, I'm going to try to pronounce it, as a biomarker to response to lurbinectedin. What is this?
Yeah, so it's pronounced Schlafen, which I don't speak German, but I'm told it's German for sleep. And
really?
So it sort of puts the cell cycle to sleep a little bit and pauses it in order for it to undergo DNA damage repair. And so what we've shown, along with other groups, is that Schlafen-11 is kind of a jack of all trades in terms of a biomarker for small cell lung cancer. It probably predicts response to platinum therapy. We see Schlafen-11 positivity in over 50% of small cell lung cancer patients, so it's not an infrequently expressed biomarker. It does seem to predict, also preclinically at least, benefit from lurbinectedin. And we found, in the paper that you had up there a moment ago, that in those patients that are lurbinectedin, or in those models rather, that are lurbinectedin resistant, and we think that's Schlafen-11 dependent, Schlafen-11 negative patient are tumors that are resistant, that you can add an ATR inhibitor and overcome that resistance. And so you can sort of decide whether somebody needs lurbinectedin single agent or lurbinectedin plus ATR based on their Schlafen-11 status. But again, purely preclinical at this point. This is murine models and cell lines.
If it ever does come to practice, I'm curious what the trade name is going to be. We can come up with something about putting the cancer to sleep or something.
Yeah, it makes for good sort of witty titles to review articles and things. Anyway, yeah.
Right. So as always, we put a bunch of review papers in the slides for you to check out. These are a couple of review articles on lurbinectedin. And any comments about the mechanism of action? This is basically chemo, or a little bit more than that in terms of how it works in terms of transcription.
Yeah, I think the impact on stalling transcription, I think, is a little bit unique for the way we think about chemotherapies. But at its heart, it does inflict DNA damage. The cell death is probably due to accumulation of DNA damage, at least partially. And the side effect profile kind of mirrors what we see with cytotoxics in small cell lung cancer. And so I think considering it kind of a piece with chemotherapy is probably the most accurate way, as opposed to a targeted therapy or certainly an immune therapy.
So there are a lot of trials looking at incorporating lurbinectedin, particularly into first-line therapy. Here's one looking at topotecan or lurbinectedin combined with durvalumab. This is a phase 3 study, the M-Forte study. This is a pretty interesting trial. Any comments on this? I guess basically trying to integrate lurbinectedin into maintenance.
Yeah, I think this harkens back to the comments we made earlier about maintenance therapy and how you have these patients that have had dramatic reductions in tumor, and then you just kind of sit on it, right? I mean, in some cases, you're continuing immunotherapy, but you're not benefiting the largest population of patients. And so, integrating more aggressive therapy into the maintenance setting, I think makes sense to further cytoreduce the tumor. There's also the notion that you may have synergy with immunotherapy, right? If you're inflicting DNA damage, that may help to inflame the tumors, whether it's with a PARP inhibitor, lurbinectedin, topotecan, the various things that are being tried in this setting. So I do think that there's a good rationale here. Down the line, when we understand the heterogeneity of these tumors better, and how that heterogeneity evolves over time, I think what we'll explore is what is actually left after the initial cytoreduction, right? Are the cells that are left over that eventually repopulate the tumor the same cells that started, or are these chemo-resistant sort of persister cells that need a different strategy to further ablate? And so they may need something more creative than just kind of throwing our conventional cytotoxics at them in the maintenance phase. But these are the drugs we have right now, and so I think it's reasonable to intensify the therapy.
So I'm curious about your thoughts. This is some data that was just presented at ASCO from the Atlantis trial that combined lurbinectedin with doxorubicin. It was kind of an interesting idea and trial. But in any event, I guess what they showed is that once they got off the doxorubicin and were on the maintenance with monotherapy with lurbinectedin, they saw further deepening of the responses in a bunch of patients. Any thoughts about this? I know there's another study, we'll bring it up in a second, a phase 3 study looking at this, but any comments on this analysis from ASCO?
Yeah, I think it's certainly interesting. It's hard to know what to make of it. The patients that went on to achieve a complete response on Lurbi monotherapy after they discontinued the anthracycline is really fascinating. I think it does call into question the trial design to begin with, and taking a good drug like lurbinectedin and using it at a different dose and combining it with a drug that I think didn't necessarily wouldn't necessarily have been everyone's first choice for a combinatorial agent. And the data, when you get onto the monotherapy portion of it, makes you think that they had a perfectly good drug there and may have mucked around with the approach a little bit too much.
So
but I think the trial you're showing here now, the Lagoon study, I think will hopefully offer a more definitive sense of what lurbinectedin really provides in the relapse setting, right? Because basically what we have now, that the FDA approval is based on was a basket study. We're looking at single arm data in small cell, basically response rate with a little bit of clinical outcome data. And it's not really been compared head to head to anything. It's clearly an active drug. I think all of us anecdotally have experience with activity of lurbinectedin. I mean, we just heard from a patient that spent a year on it as at a dose reduced level. But we want to make sure it's better than the other drugs that we have, right? And so I think we need a definitive study for it.
All right, let's see if we can close out with a couple quick cases. This is from Dr. Patel, 72-year-old woman who's currently smoking and received dose attenuated chemoimmunotherapy because of her comorbidities. Here's Dr. Patel.
I have a 72-year-old. She had a history of COPD emphysema and a 60-pack year history of smoking. She was an active smoker. She had an abnormal low-dose screening CT, which picked up some focal pleural thickening in the left upper chest, measured close to 1.4 centimeters in diameter on the restaging studies, and then also had development of progressive pleural scarring. And so on her PET scan, it confirmed that she had a 5-centimeter area of pleural thickening in the left upper lobe. And so we ended up doing a CT-guided biopsy, and it confirmed that she had a small cell carcinoma. Her baseline ECOG performance status was a 2, and she was dependent on 3 liters of oxygen chronically. We ended up giving her attenuated doses of carboplatin, etoposide, and atezolizumab. She actually had went into a very good partial response, a marked reduction in her pleural thickening, sent her to the academic center, and they treated her with 30 gray of radiation just based on the CREST trial there. I guess one question is, I know you can still use topotecan, but I've used it once and saw pretty profound cytopenias and side effects, and so I've switched to lurbectedin as a second line option, but wanted to see what the experts would suggest in optimal sequencing.
So a bunch of issues there. Lots of times you see people with comorbidities like this woman on oxygen. Any thoughts about this case?
Yeah, I mean, this is a pretty typical case, unfortunately. A lot of these patients have a poor PS. The heavy smoking history that comes along with this disease so often that doesn't help. And the disease is so aggressive that it imposes a lot of symptoms on its own. And so, I think it's always reasonable to treat somebody with small cell lung cancer that wants treatment because you have these profound and almost immediate responses. And so I think this is absolutely the right thing to do to try to get at least, dose reduced levels here into the case, and then to consolidate with radiation. In the relapse setting, if this patient does relapse, it wasn't clear that they have yet. I agree that topotecan is tough. I don't want to come down too hard on it, but it's not a great quality of life drug because of the cytopenias and because of the way it's administered, right? 5 days in a row is not a great, lifestyle for somebody that's just seeking palliative benefit when they're nearing the end of their life. And so I think, going back to the case earlier where a dose-reduced version of lurbinectidine was active, this is a case where I might consider starting at a dose reduction, such as one dose level below at the 2.5, and then considering if a patient tolerates it really well, you can always go up on it, right? But you don't want to cause them any problems right out of the gate.
So, Carl, it's been so great to work with you today. We didn't even get to several of the cases. I got more cases in the chat room. Patient with Eaton-Lambert syndrome. I'm going to guess you wouldn't be giving that person an IO, but anyhow, I think we'll just call it a day. And thank you so much for working with us today. Audience, thank you for coming on. Coming back next week on Thursday, we'll be working with Dr. LaRue. We were talking about ovarian cancer before. We'll see what she has to say about that. Be safe, stay well, and have a great night. Thanks so much, Carl.
Thank you. It was a real pleasure.